So what can we do for these patients? Well, we can block them. We can also inject Botox, and patients also undergo ablation of the cervical facets. So first, we have to think about it, because we will not see it if we don't think about it. So patients have brain MRs for headache. They also have cervical MRs. And unless we go way out laterally, like on the sagittal T2, we may not necessarily see it. Or even if we cover it, we may not recognize it. So here we have marrow edema at the C1-2 articulation of the lateral mass, some fluid in that articulation. And what is it compressing? It's this structure here, which is the C2 root. And this C2 root is bigger than the normal left C2 root. So this provides some evidence for intraneural injury or edema by degenerative changes, and that's confirmed with CT, which shows the obliteration of that articular space with sclerosis and erosions compatible with degenerative change. So with CT guidance, we're able to access those areas and to inject for pain relief. Surgically, one can undergo arthrodesis or neurolysis, or you can also place spinal cord stimulators to try to help out with patients with cervical-related headache. Here's a patient with bioccipital headache, and we can see osteophytic changes at the C1-2 junction, here in the axial view as well, and the sagittal view. So she underwent C2 nerve blocks bilaterally, here under CT guidance, and you can see the needle right at the level of the C2 root bilaterally, and we can see the anesthetic and the steroid mixture nicely coating the C2 roots with cessation of her headache, which lasted at least half a year. A group has looked at the utility of these, not just for therapeutic purposes, but also just like our sciatic nerve blocks, to see if it might also identify a patient population that might undergo surgery for decompression. And so you can see here a diagram showing the needle at the C2 root, the injection, and also the planned decompression with taking off of the posterior elements of the C1. So not only is it diagnostic, it can be therapeutic, and can also identify a patient population who can benefit from surgical decompression. And so we had a patient who actually underwent decompression. This is a 91-year-old MIT graduate who was very active and had a good result with his decompression decades ago, but then started to have recurrence of his symptoms. And on his MR, you can see that the T1 post-SCAD images shows extensive enhancement of scar tissue at his prior surgical site. And it was entrapping and enveloping that C2 nerve root, which you can see here in the asterisk. Compare that to the more normal left side. And so this very active 91-year-old male really needed to have something done because he wanted to be able to take care of his wife, and he wanted to remain active. And so the CT, you can see the soft tissue, which was our target for the CT-guided block, and you can see extension along all that scar tissue, and this dramatically decreased his pain, enough so that he was able to take care of his wife and to resume social activities. And that can be just such a gratifying thing to be able to do, and that's really why we're here, to be able to see if we can take the imaging techniques that we have to continue to advance them along with our clinical colleagues to find pain generators that were not necessarily thought of before, and then to use those same imaging techniques to precisely target areas so that we can continue to provide ways for patients to have such a high quality of life. And that's what keeps us going, and that's our challenge. And so just in summary, just remember that there are extraspinal areas of pain that we need to remember to look for. Headache and buttock pain can be spine-related. We can offer diagnostic and therapeutic non-operative management in a safe and precise manner. And really the challenge to us is to continue to work towards that goal and to help the patients that we see every day.